Okay, let's get started. It is 1 o'clock Eastern Standard Time. Good afternoon, and thank you for joining the Superior Health Quality Alliance Roundtable conversation. I'm Kim Heft, and I am joined by my colleagues, Janae, Jerry, Keisha, and as well as our guest speaker today, Constance tetrev. We host these 1-hour sessions on the second and fourth Wednesday of the month. The first half is a didactic presentation, and then the remaining time will be left for Q&A. We're going to put the link for the PowerPoint presentation into chat momentarily. Use that chat box to share your comments, questions, anything that pops into your mind during the presentation, and we'll use that for a discussion in our Q&A. Please, and also, feel free if you ever want to raise your hand, and we'll, if you just want to talk freely to ask your questions, sometimes that is just so much easier than typing into chat. We encourage that. We're also going to put an evaluation link in the chat afterwards, and like towards the end of the presentation. If you could take a couple of minutes to complete that, we'd really appreciate it. And so getting here for today. So what are we doing today? So today we're going to continue the discussion on immunizations and infection control. It's almost October, and maybe some of you have started vaccinating for influenza in your nursing homes. Can you give me a thumbs up if you started influenza vaccination in your facility? Down at the bottom, there should be a tab and it says reactions. Do we have anybody that's actually started, has done clinics, given out vaccines for influenza? What do we have here? We got a couple. It's so hard for me to see both, but yeah. All right, good, excellent. I just can't believe October's here, pretty much. So, okay, good. What else do we got going on here? Well, yes, all right. The 2023-2024 COVID monovalent vaccine was recently released. Any vaccine given after September 12th of 2023 is the new monovalent, new vaccine. That previous bivalent vaccine is no longer available. We just have the one and done. Next question I have for you is, are you seeing an uptick in the number of COVID cases in your community? Can you also, if you are, can you give me a thumbs up if that's the case? 2, 3, 4, here we go. Yeah, 5, 6. Okay, yeah, I hear you. I hear you on that. According to the data from the CDC, so this was week ending 9/16, and then comparing it to the week prior, COVID hospitalizations in Michigan were stable, no change. Minnesota's hospitalizations, they have increased by more than 10%, and Wisconsin by more than 20%. Now, unfortunately, fortunately, we have a fortunate side to this. There are states that have decreased, but we're not one of them thus far. My next question, is there anyone having difficulty getting the 2023-2024 COVID vaccine, or if you do, you need a clinic? Because Superior Health, we can help with this. If you send me your contact information, we can discuss this further, and we can get a mobile vaccination clinic set up for you. My colleagues will drop some of our email addresses in chat, so please reach out. Okay, our next 2 roundtable sessions, just in case we run out of time, are on October 11th and October 25th, and we're going to be changing our focus. We're going to be talking about diabetes management for our long-term care residents. Okay, so that leads us now to our feature presentation. Constance tetrev, she's an RN with Innovative Insights Consulting. She's going to get us started. So welcome, Constance.
Hi, everybody. As she said, I'm with Innovative Insights Consulting. I have been a nurse for 20 plus years, and I recently, in the last 5 years, have become a clinical nurse consultant. And this came about right before COVID started to happen. Slightly before that, I got some experience. But when COVID outbreaks started happening, I assisted with DPOCs. So I would go into COVID hotspots and I would help fix their problems in infection control and help fix their fix surveys. And so give them education, get them back in compliance with CMS and with the state, and train them on how they can make systemic and sustainable changes that they could continue to use. So that's kind of where I have started my experience in consulting. But since then, I have built my own business based on trying to make changes that are more systematic and more systemic, so that companies don't need to pay consultants to have to come in, or they don't have to pay surveyors or the state fines for these type of situations. I've kind of been driven to identify and develop and improve collaboration using clinical platforms that have successfully rolled out programs that improve the efficiency across healthcare systems in nursing homes and in senior living. And because of that, I have some expertise in just looking at a system and improving it from the ground up, the foundation up. So today we're going to be talking about infection control, which is a love of mine. I love quality improvement and infection control. I have a real passion for it. As that experience from the pandemic, it definitely gives you a different look at things, and it also gives everybody else a insight to what you love. And a lot of people wouldn't know about all these things except for the pandemic. So all of the slides that I'm going to present today, and you can go to the next slide, are going to be stuff that you have already seen. You've seen this a million times, except for maybe the new model or the new COVID vaccination and the new RSV vaccination. You've seen all this stuff, but I'm going to give you some experiences that I have had in my career, that whether it happened to be a good outcome or a bad outcome, and what happened in between, so that you guys can learn from what I've experienced. So next slide. Okay, so our objectives today are to increase the understanding of infection control measures and enhance our knowledge about the role long-term care and you and I as professionals play in it, and infection control and immunization practices. Then we're going to address the vaccine hesitancy and strategies to overcome that, because that's one of our biggest problems in our jobs every day, is to how do we get those people that are refusing to get a vaccine, that have myths and misinformation that has been presented to them, how do we get them over that hurdle and see if they can make an informed choice? And then we want to engage healthcare providers in promoting vaccine confidence. So we want you to be confident in giving that education, overcoming those barriers that might be there in the communication and the learning process, and get you to where you want to be. It's important for everybody to be vaccinated. Obviously, we have an endemic. It turned from pandemic to endemic. So we want to make sure that we can promote and ensure people are healthy in our communities. So we didn't get into being, I know I didn't get into being a nurse because I didn't want to improve people's lives. So a lot of what we're doing is trying to overcome that barrier and engage you guys in that process. Then we want to foster collaboration and action for infection control and immunization programs. I do see an uptick in hospitalizations for COVID infections. We are seeing a lot more in the community. I follow a lot of streamers, and they're talking about hospitalizations tripling because of the fact that COVID is still around. Next slide. The importance of infection control and immunization practices in nursing homes. So we are working to prevent the spread of infections. We're in a small populated area. So when we are in close confinement, it is very easy for communicable diseases to be spread very quickly throughout a nursing home, a jail, a assisted living, those real close confinement areas, schools, colleges, dorms, things like that. We want to protect our vulnerable residents. And we do that by ensuring that we have practices that allow us to prevent the spread of infections, hand hygiene, PPE wearing, and to ensure and enhance the overall resident well-being. Again, we're not in this because we want to just make a lot of money, right? We're in this because we care about the people that we're serving. So when we're thinking about enhancing their lives, that we have to adhere to infection control practices. Next slide. So one of those key infection control measures is hand hygiene, using proper hand washing techniques. And again, we're here and we've seen this a million times, right? And use of hand sanitizers. So these methods have been proven to reduce infections so significantly that they cannot be missed and not lead to tracking back infections. I've seen multiple facilities where I can go through just from afar and look at their infection rates, their IPC programs, and I can tell you that there's somebody not washing their hands because there's 3 people with C. diff. There's 4 people with UTIs, all on the same areas. You can see where the hand hygiene must be breaking down. It's not always the case, but a lot of times it is the case. You can see that there are practices that are decreased, whether it's because we have lots to do and have lots to get through and we just missed it, or we can see that. So going through these measures and teaching our staff over and over and over, a lot of times becomes a lot like the stop, drop, and roll. I mean, I haven't used stop, drop, and roll ever in my life, but I remember it because it was so ingrained into us that it becomes a part of process that it kicks in, even if we can't remember it, right? We're on fire. It's, anyway, next slide. So hand hygiene promotion and proper hand hygiene is one of the most effective ways to prevent the spread of infections. Infection control promotes and reinforces the importance of hand hygiene among healthcare staff, patients, and visitors. This includes regular hand washing with soap and water or using an alcohol-based hand sanitizer, especially before and after patient contact and performing invasive procedures. There used to be a requirement for after, I can't remember if it was 5 or 6 times we used hand sanitizer that we needed to go and wash. That is no longer the practice anymore. It's not the standard of practice. It's only if you're, not only, when your hands are visibly soiled, when you've came in contact with something that soils our hands. So it's remembering to keep that as a process in our policies and procedures and make sure we pull out those things that aren't necessarily standard practice anymore or best practice. Next slide. Another key infection control measures is the personal protective equipment. The gloves, the masks, the gowns, and the eye protection. This comes into play when we have infections in our nursing home and we are trying to protect all of the other residents as well as ourselves and not transfer these infections and these microorganisms and viruses to other people. One of the biggest things that we did learn during the pandemic, and a lot of people will understand this, is that we did not have enough of stockpiles in nursing homes across the country. We didn't have enough equipment to ensure that we were prepared if something bad did happen. So we were reusing a lot of PPE. One of the things, I still teach a standard precautions class for CDRF registry people in Wisconsin. And in that standard precautions class, I show them, and I would encourage you guys to use Glowgerm. Glowgerm is a kid product, and it is a powder or a liquid that you can spray. And then you spray it on your PPE, and then you put it on. And if we're reusing, we have to take it off. We have to don and doff differently, right? And when you take it off, you can see it transfers the cross-contamination. You can see exactly where it cross-contaminated by using a UV light. It was very interesting because during this, I was teaching lots and lots and lots of different facilities in Michigan, Minnesota, and Wisconsin, how to don and doff. I was not able to, in the entire time of the last 3 years, don and doff without cross-contaminating. not a single person in any of my classes was able to don and doff without cross-contamination. That's a significant thing for me because we're reusing that, and then we're going to the next person and the next person, and we can start to see how these infections spread. That was big for me because I thought I was doing a great job. If I can do it, I'm training them on how to do it. Shouldn't I be able to do it properly? And I bet you that I didn't try that probably 30 times at home on my own and could not cross-contaminate. So one thing that we did learn during the pandemic, that across the world, it was an issue. We had to learn how to don and doff differently. It's not exactly the same when we're using reusable or we're using reused items. So that was really important from my career to be able to explain, look, this is a good explanation. This is a good way you can see it. And it helps people that are visual learners to understand where there might be issues. I haven't overcome it yet, but next slide. So do we skip one? I feel like I skipped one. That one. Yep, next. Okay, there we go. Isolation precautions. So when we're talking about isolation precautions, we're talking about how we try to segregate, we kind of isolate a person either from the other population to try and keep them, keep their infection with them, not have a significant amount of people get it. During COVID, we learned a lot about how it can be spread, and it spreads through airborne or droplet or contact precautions. And we use this in every infection with, whether it's MRSA, VRE, we use it with C. diff, and the differences in how we treat people. So we are treating them based on whatever infection they have, but what measures do we have to take that are separate from each different infection? So the biggest one is C. diff and norovirus. I tell all my standard precaution classes that you will know that there's C. diff or norovirus in your building. And how you will know is all of the hand sanitizer will disappear. It will not be available to you. You won't be able to find any. And you'll question, like, where's all the hand sanitizer? And that was actually a question on my test was, where's the hand sanitizer? Well, there's norovirus or C. diff, because those two infections do not have enough of the virus killed with hand sanitizer. There's still spores of C. diff left on. There's still norovirus. So the hand sanitizer goes away because it's not an effective mechanism in killing it. So we use bleach products. We use soap and water for that. Those are your two major ones that you can see a difference in how we treat people based on an infection. So not only does this include implementing contact droplet airborne precautions based on the mode of the transmission of the specific pathogen, but it also includes those people that might have a pathogen that kind of just sits dormant in their body. So your VRE that's already been treated, they don't have symptoms of it at this time, but it still can pop up. They're colonized with that. So it also includes the enhanced barrier precautions. Not all facilities use those, but they continue to use the contact, but there are enhanced barrier precautions. So if you only come in contact with that, that mechanism, then you would use precautions during that time. Isolation precautions involve using all of the PPE and maintaining proper ventilation and ensuring a proper patient placement to limit the transmission of infections. So we're ensuring that we don't pass it from person to person. And one of the big ones is MRSA and VRE. We have seen studies that have shown that they are transferred more easily in a nursing home, and they can go from person to person and be picked up on hard surfaces. So go to the next slide. It's really important to have key infection control measures such as environmental cleaning and disinfection, regular cleaning of surfaces and objects. We saw that our highly used surfaces, we needed to disinfect them more often during the pandemic, and the use of appropriate disinfectants. And everyone here has cleaned something in their home. You probably didn't think about it until after the pandemic or during the pandemic of how we were using those cleaning products. A lot of people didn't understand that not only did you clean the surface of a product with the product, but you also needed to leave it in contact with that surface for a certain amount of time. And each different chemical, each different product that we use has a different amount of contact time. And so it was really important to know that contact time for COVID and for MRSA, VRE, Hep B, HIV, any of those things, C. diff. It was important to know exactly what chemicals we needed to use, that we were using the proper one, and that we were using them in a proper mechanism to allow it to kill the virus or the infection or the bacteria. Next slide. Environmental cleaning and disinfection. Obviously, infection control oversees the implementation of the effective cleaning and disinfection practices in healthcare facilities. This is all throughout any healthcare facility. This includes routine cleaning of patient rooms, equipment, high touch surfaces, using the appropriate disinfectants, as we discussed, and then the proper cleaning and disinfection that helps eliminate or reduces infectious agents present in the environment. This leads to a decrease in the risk of HAIs, healthcare associated infections. And it's likely that your first case of COVID wasn't an HAI. It may not have been brought in they could have been out in the community and they brought it back, right? And have an infection. It wasn't started there. But every infection after that becomes an HAI because each time we have to have such procedures that try to prevent the spread of it, right? So when doing that, we're tracking all of that, and that leads to poorer outcomes, different decreased quality measures, increased survey, findings of deficiencies. Next slide. And so when we use these practices and we look at them all in a greater, grander picture, we can see how these few things help us to reduce giving those vulnerable populations infections that we can prevent. Another key infection control measure, and we saw this a lot during the flu season, was respiratory hygiene and cough etiquette. Who has that? Just by raise of hands. You remember that sign that always came out right around October, and then it would have a stand with it where it had Kleenexes and masks and hand sanitizer. It always was set at the beginning, the front of the building, and you were telling people, hey, don't visit us if you have these symptoms. Well, they stay out now, but I mean, we all saw that sign, whether you were going to the clinic, whether you're coming into the nursing home, whether you're going into the hospital, they were saying, hey, don't visit us if you have these. And then it reminded you what the etiquette was, not to cough and sneeze on your hands, not to just leave your Kleenexes around, because that's a really high risk way for other people to get it, right? By covering your mouth and your nose when you're coughing or sneezing, and proper disposal of your tissues. Oftentimes when we have a cold, the entire house gets the cold. Why? Because the mom picks up the Kleenexes and she isn't wearing gloves because it's at home, right? And then it goes from the mom to the son to the entire family, and within a month or two, everybody's had the flu or the cold viruses. That's a lot of times because we didn't use proper key infection control measures at home. Next slide. So another way that we can prevent the spread of infections is by the implementation of standard precautions. Standard precautions is a set of infection control practices designed to prevent the transmission of infectious agents. They include hand hygiene, the PPE, safe injection practices, and respiratory hygiene cough etiquette. Infection control nurses often ensure that these precautions are consistently implemented by healthcare staff, reducing the risk of transmission of infections between patients and healthcare workers. They provide education into who, what, where, how, and how can we better improve these practices. They don't just take the notes down and say, here's so-and-so's infection and here's our QI. They actually implement practices that try to look at and dive down and provide an analysis on where infections are coming from and how we can improve. Next slide. And this is important to our facilities. The next thing which we're talking about is surveillance and monitoring. Infection control collects and analyzes data on HAIs within the healthcare facilities. So they look at all the UTIs that are going on, and they have a line list, and they document whether they're starting to have symptoms whether a UA has been ordered, whether a antibiotic has been ordered, and the progression of those symptoms. This includes tracking infection rates, identifying any trends, and monitoring the effectiveness of infection control practices. Surveillance helps to have an early detection of outbreaks or clusters of infections, allowing prompt interventions and prevention of further spread. So an example of this was my very first directed plan of correction through the state of Wisconsin. And I was given all of the information, all of their line lists, everything long before I ever came to their facility. And I had a table full of exactly what I was tracking. I took their line lists of who had symptoms, when they started to have symptoms, and when they became infected. And I probably had a paper that was the size of a large table, and I tracked it all the way across, and I brought it with me to my first day. And I said, here's what I see from afar. I see that this person was the first person to ever have symptoms. This person wasn't a nursing home staff member. They were a assisted living staff member. And the missed portion was they all used a common site. They used the common cafeteria. And because all of those people in the assisted living, the independent living, and the memory care, along with the nursing home, all used that site and that cafeteria and that break room, there was a large exposure. This exposure was so significant that all but two residents in the entire facility had COVID outbreak. All of the staff, all of the staff, including all of the key leadership, were out when state walked in the building. Their infection control, their MDS nurse, I think the director of nursing was there. No, the assistant director of nursing was there, but then she became ill, and their staff, it was such a significant outbreak. It was the largest one I had ever seen. Of course, it was my first, but even in being an IPC person, it was the largest one that I seen. So all of these things track into how you can look at things from obviously, I can look at it from a different perspective than somebody that's in the facility, because I can take a look at everything. And sometimes we get real focused into how we see things. We get very narrow vision, like, oh, well, it was just this person. But they couldn't see that there was that commonality. And so the infection spread. They did see it after they were cited and state walked in, and they received their directed plan of correction. They're doing great now that they've had all the education, but that was a significant event for them, and it could have been prevented. Next slide. So education and training, they also focus in on the education and training, just like I said. Infection control provides ongoing education and training to healthcare staff on infection prevention and control practices. This includes training on proper hand hygiene, PPE use, safe injection practices, proper cleaning, disinfection techniques, and adherence to isolation precautions. Education also extends to patients and their families, empowering them to actively participate in infection prevention measures. A lot of facilities have certain key leadership roles go and meet with new admissions and explain what their process is and what their role is and what they're looking for information from them. One of the practices I saw was oftentimes IPC nurses go and interview the resident to see what vaccinations they have. This is a really, really important key role that IPC do, because then they have an opportunity to try to hit on those objectives that we were talking about. We're trying to engage our staff to do those things. We're trying to see if there's any way that we can protect them long before they ever get an infection, even if they come with an infection. So we're looking for ways that we can protect them. Another key role that they have is in administering of immunizations. They order and administer the flu shots, and not with COVID shots, but pneumonia shots. The vaccinations for RSV will likely be administered by a professional. And they also administer TB tests so that we can look for infections that are related to TB. And all of these practices are all about what we're talking about, but they're also key because they give education to the patients over and over and over to allow them to absorb what little that they can absorb each time they see that person. Next slide. They work to collaborate and communicate. Infection control collaborates with all of the different departments in healthcare, and especially in nursing homes and skilled nursing facilities, in their teams to ensure a multidisciplinary approach to infection prevention. I'm sure you talk a lot about any infections that happen throughout your building in your stand-up processes. Every stand-up in the morning should have a process where they discuss all of the infections and what changes we need to make. It's where other IDT can collaborate with them and talk to them about what they're seeing on the floor that maybe IPC or the DON or the administrator is not seeing. Effective communication and collaboration among healthcare workers, including nurses, doctors, support staff, and are essential to implementing and sustaining infection control measures. Not having a communication process is the downfall of almost all of our processes, right? So if we are unable to communicate the things and there is a blockage in how communication flows, you can see process breakdowns. You can see infections increase. You can see wounds increase. You can see all of those practices or all of those things that we are trying to prevent increase if there's not communication. Next slide. So now we're going to talk about how immunizations play into this role and the importance of having immunizations. Vaccination as a key preventative measure is highly important for our vulnerable populations. And this may not just be your residents. This may be your staff members. This may be you as an administrator. It might be your director of nursing that has a autoimmune condition that they are more susceptible to have infections. So we need to have vaccination programs to ensure that we have protected environments for those that cannot have vaccinations because of chemotherapy or autoimmune processes. They reduce disease transmission within nursing homes significantly. We used to talk about it in the essence of influenza and pneumonia, but now it's more towards COVID, and we're now seeing RSV be key initiatives that we are trying to ensure that we reduce disease and communicable disease, especially transmission within the nursing home. We're ensuring that we're protecting residents from vaccine preventable diseases, and we are enhancing the availability of herd immunity for those people that cannot vaccinate. So there are people in the community that either choose not to or cannot be vaccinated, and we need a substantial amount of us to be vaccinated in order to provide them with herd immunity. Next slide. So here are the recommended vaccines for nursing home residents, and we've all seen these, except for the new RSV, the influenza, the pneumococcal, the COVID-19 vaccines, the shingles vaccination. Obviously, Tdap and Hep B are in that population. They're looking for those when you do come into a nursing home. We offer those, but it's not as much of a significant focus. But the other 5 are significantly important in preventing those communicable diseases that we can. Next slide. And I did put some references there. They are clickable, I believe, or highlightable. So you can go to those sources. So immunizations for age 50 to 64, most commonly administered vaccines in the nursing home and in long-term care or skilled nursing. According to the CDC, for people 50 to 64 is the COVID-19 vaccine or vaccines, the influenza vaccine, the shingles vaccine, and the Tdap. I don't think I've ever given a Tdap, but I'm just saying. Other ones that may be needed, again, are the Hep B vaccine, the MMR vaccine, and now the new RSV vaccine, which is adults age 60 years or older should talk to their healthcare provider about getting a single dose of the RSV vaccine. And again, another link that's there. Next slide. And then the 65 plus, most commonly administered, is again very similar to the 50 to 64, the COVID-19 vaccines, the influenza vaccine, shingles vaccine, and the Tdap. I also give a lot of pneumonia vaccinations too. I don't know why that's not on the list, but from the CDC. But the RSV vaccine, again, for the 60 years or older, they should definitely be talking to their healthcare provider, whether it's the facility medical director or their own provider. Next slide. I'm trying to get rid of the fly. Another thing that we talk about when we're talking about vaccinations is consent. So this is where we get into our objective about overcoming any barriers, right? So a lot of times if our loved one is not able to ask questions or otherwise communicate with our staff, I wanted to put some key things that we should know about consent for getting a COVID-19 vaccine, because we have a new vaccination out there, and in order to be completely vaccinated, we have to follow the algorithm and we have to have that vaccination. So consent or assent for a COVID-19 vaccine is given by the long-term care resident or people that are appointed to make any of their medical decisions on their behalf, called a medical proxy, a POA, a healthcare, I can't even think of any of the others, guardians. There's another one, a durable medical power of attorney as well. So those people are being a proxy, and they are making decisions on behalf of the person that is unable to either communicate or unable to make that decision for themselves. And then it's documented in their charts per the provider's standard of practice. And that may be that you guys document, yes, I received verbal consent, and then they come in and sign a consent and we send it out. Or maybe it's they have and I always recommend this, having a consent and a declination form for every vaccination. It allows you to have proof to state surveyors that show that you did talk to those people, that you did give them all of the education, because they will question you about that, and that they did in fact decline. They don't always rely upon, hey, so-and-so declined, and I wrote it in their chart. Having them sign something is very important that shows that we gave them all of the information. Residents who receive a COVID-19 vaccine or their medical proxy also receive a fact sheet before the vaccination. The fact sheet explains the risks, the benefits of the COVID-19 vaccination, and this is with all of our vaccinations that we might give. And some COVID-19 vaccination providers may require written, email, or verbal consent from recipients before getting vaccinated. This is at the provider's discretion. For COVID-19, a lot of times they will send the pharmacy that is providing you with a vaccination clinic will provide you with what they want you to have or what they want residents or employees to sign. And that way they'll have all of that on their records as well as yours. Otherwise, you would need to have a form, and it's based on your policies and procedures. Sorry. Before getting vaccinated, this is at the provider's discretion. Written consent is not required by federal law for COVID-19 vaccination in the United States. So written consent is not required. I would always encourage you to always have written consent, even if you get verbal, just because it allows you to show the processes of how you educated the person. Residents or their medical proxies can get vaccination cards or printout that tells them which vaccines, COVID-19 vaccines they have received, and all the ones that they have received. I know in the state of Wisconsin, we have the Wisconsin Vaccine Registry, which I would love for it to be a national thing because it'd make life easier. If their vaccine card is full, the vaccine provider can provide them with another card, but they don't provide them with a card if they lost their card, if that makes sense. This should also be recorded in their medical chart. So all of their electronic health records should show what vaccines they received, whether they consented, and what information was provided to them. If you're using PCC, that's a really easy process. So next slide. So not only do we have to immunize our residents to ensure that they are healthy, but we also have to ensure that our healthcare workers, our HCWs, are vaccinated and not giving out communicable diseases, right? So the vaccines that they could need if we work directly with patients or handle materials that could spread, everyone in this room, if you're working direct care. And you should be getting vaccines that are appropriate for your age, and the CDC goes through that, but you can go through that with your medical provider to reduce the chance that you will get or spread vaccine preventable diseases. So all healthcare workers should make sure that they're up to date on the vaccines that are listed: COVID-19, the varicella vaccine, influenza vaccination, hepatitis B, which is always offered by our facilities and when you work in healthcare and it's provided at no cost. The meningococcal vaccine, and I always screw that one up, especially lab workers who work with I can't even say that, meningitis. The MMR vaccination, the Tdap vaccination, next slide, or the TD vaccination. And a lot of these can be pulled via a titer to determine whether or not they are ready. And all of Wisconsin, or the registry people, can see where they're at on their vaccines, as well as their medical providers usually have that on their after visit summaries. Other vaccines that they might need for healthcare workers could be the HPV vaccination, recommended for adults ages 18 through 26 and adults 27 through 45 based on shared clinical decision-making with their provider, and the shingles vaccination, which is recommended for anybody that's above 50 years or older. And it's also based on whatever their medical conditions are in their immunostatus. So that would be discussed with their healthcare provider, whether or not they can have those vaccinations. Next slide. So here's what we need to know for healthcare workers. The CDC recommends everyone, including people that live and work in long-term care settings, stay up to date with the COVID-19 vaccinations for their age group. Everyone 6 years and older, children aged 6 months to 5 years, and people that are more likely to get very sick from COVID-19 can get additional updated COVID-19 vaccines, and you can learn more on the CDC. People who live in long-term care settings must give consent or agree to getting a COVID-19 vaccine. But like I said before, the federal government doesn't require that they have a written consent. COVID-19 vaccines are free, and so we want to ensure that we provide them and give everybody an opportunity and education based on that. Next slide. If you live or work in long-term care setting, you can help protect yourself and people around you by staying up to date with your COVID-19 vaccines. They're safe, effective, and especially against becoming seriously ill. This is a significant conversation that I have with hesitancy, is it going to prevent you from getting COVID-19? Maybe, sometimes, but it's not 100%. So it will reduce the risk of mortality and being on a ventilator. It will reduce the risk of the outcomes that come. It's just like influenza, where when I say that, I don't mean it like that. It's a lot like influenza when I say that you still might get influenza, but you're less likely to die from influenza, especially in the elderly or the young, and you are less likely to end up hospitalized. Doesn't mean you won't have any symptoms of it or that it'll prevent it completely. Older adults and people with certain health conditions are more likely to get very sick, and we saw this throughout the pandemic. We saw that, what was it that was predicted 1%, and that the very young kids in school would be just fine. Well, they weren't just fine. There was a lot of kids that had problems with with not having a vaccine. So then we rushed out vaccines, and we thought, oh, well, it'll only affect just the elderly. Well, if I have 10 more years with a person versus having only another week with them, that's a big difference to me. I don't want that 1% to be affected by this if we can prevent it. They can help keep us safe and keep you from getting seriously ill if you do get COVID-19. I was vaccinated. I didn't get it for 2 years, but I cannot imagine it being any worse than it was, even vaccinated. So I just really implore people to get vaccinated. It really helps us. Next slide. Helps us to protect everybody. So some vaccine strategies that we can use are collaborating with healthcare providers and pharmacies. So we collaborate with the pharmacies, whether it's Walgreens, CVS, or your long-term care pharmacy, to ensure that we have availability, that they'll come in and provide vaccine clinics. This reduces the load on the nursing home staff. We all have enough load on us of work that we can be doing or getting done, right? So it does help us to reduce that load. We're not giving those vaccinations. We're just doing the education. We're just doing these other practices and entering them into the medical record. We can ensure accessibility and availability of the vaccines. We can ensure that we're providing that education on where we can set up clinics, how you can get to a clinic, when we'll have our next clinic, and what residents can expect, and answer that education piece. We can educate residents, families, and staff about the importance of immunizations. We can implement vaccination campaigns and clinics. So we want to really hit on that, getting out the misinformation and making sure that we look up the myths and the misinformation that's out there, so that we can find ways that we can explain and educate based on that misinformation. Next slide. So some of the challenges in infection control and immunization is staff education and compliance. I can think of every facility that I've gone to where I ran into brick walls a lot of times with education and the compliance of COVID-19 vaccinations, or vaccination with influenza. I would be super rich if I received $1 for every time somebody told me that they can't get the influenza vaccination because they get sick right afterwards. And I'm always praising them. I'm like, yeah, that is so awesome. Do you know what just happened? Your body mounted an immune response to a vaccination. That is great news for you. I am really excited for you because your body acted in the appropriate manner. It's going to mount a response to that. That's good. Yes, you're not going to feel great, but it's exciting, because if it didn't, that would be a major problem for you, right? So I try to change the narrative of how they're saying it and saying, oh, I'm excited for you. That's good. I know you might have thought that you got the flu from the influenza vaccination, but here's the information I have for you. It's not a live virus. It's your body doing what it's supposed to. That's really kind of exciting for you. There are people that don't have that experience, right? So sometimes that changes people's minds, having that excitement about it. The vaccine hesitancy among residents and families. So there is a ton of information out there that talks about all the bad things that a vaccination can do, all of the side effects that you might have. And just trying to hit that where, yes, you could have it, but not everybody has that. Not everybody has a reaction. I had a sore arm. I really did. I had a really sore arm. I don't think I got sick though. I got it as soon as it was available to residents. Maintaining accurate vaccination records. This is one of the biggest things a lot of people get F tags for, is not having an up-to-date and accurate vaccination record. So maintaining those vaccine records for residents, for your staff, and having a system that works to ensure that all that information gets handed off from person to person. With our residents, we're receiving a card back. A lot of times they're just giving it to the staff. And so what happens when that IPC person leaves that position? Where does that information go to? It should always be in the electronic health record, but where does that card go to? Where is their hard chart? Where are we keeping all of that really important documentation that they will not replace for that person should they go to another facility? Yes, we can provide them with the printout, but a lot of people are really concerned about that card and how we maintain that accurate vaccination record. A good example of this was when I was an infection prevention or preventionist in a nursing home. It was the first time I had been an IPC, and this is like 10 years, 15 years ago. Telling my age here. So I was sitting with surveyors, and I hadn't been in a survey in a very long time. I had been in the hospital setting. So I came back to long-term care, and I was sitting with a surveyor going over my process. Mind you, I had only been in this position like 2 months and barely out of my IPC class. And I was going through and I was like, no, I know this person, and I had a process for everything, but my process was brand new. And so I was still learning all of the residents. We had still paper records for all of the things that happened before we turned to electronic health records. For 2 hours, I sat with a surveyor going over and being grilled on my IPC process. And there was still one thing that was left, and it was a pneumococcal vaccination, proving that one resident that had been there for 13 years had it. Now, mind you, I've been there 2 months, so that's a really difficult process. But I knew that we had the information. I knew I had seen the information. but it hadn't been uploaded to the new EHR yet. And so I went back to the paper records, and it took me 2 or 3 hours before I was done being grilled to provide them with that information. But in that 4 hours, I went back and I was able to prove exactly that that person had had it. And I went through their entire file cabinet, because this person had so many records, to ensure that they knew that this process was solid. Yes, it's in paper, and yes, it should be scanned in, but the process that I had was solid. We did not receive any citations from that. And because of that, because of my doggedness, it was important to show that we were doing what was in the best interest of that patient. Adapting to emerging infectious diseases. We're seeing us adapt. We adapted when HIV came out. We adapted when the pandemic happened, right? We're adapting to that process. A new emerging infectious disease is, and I cannot remember the name of it, but it is a candida. And it is a fungal infection that is very resistant to any of the treatments and medications that we have. And we are starting to see that when it comes, it goes everywhere. It spreads like wildfire, and it's very hard to get rid of. You can't get it out of the soft materials. And so it's a new emerging infectious disease that we're having to plan for in infection prevention. Next slide. We have to plan and come up with processes. And a lot of this happens during our facility assessment. Ongoing staff training and education. So our IPCs have the ability to provide ongoing staff training and education, effective communication with our residents and families to kind of overcome these challenges. And then they utilize the electronic health records for vaccination tracking. This includes maybe pulling the registry, pulling the documentation from their admission to make sure that it all gets into your EHR, but making sure that all of that information transfers. And while we have a lot to do, this is a really important way to prevent you from receiving a citation for something that is easily fixed. We want to stay updated with the infection control guidelines and best practices. We want to stay updated with evidence-based practices because they're always changing. And we have a system that we saw when the pandemic hit, that there were different recommendations from a state, a county, and a CMS or a CDC level. And it's trying to make sure that we follow all three to ensure that we're protecting patients and our staff and ourselves. So making sure that we stay updated with the infection control guidelines, sending our IPC to any I cannot think of the word, but sending them to collaborate with other people, making sure that they have the time to look at what the new recommendations are, being on the CDC calls, the CMS calls, having them be a key partner in that information where they can receive all that information. And it's really important with the new RSV and the new COVID-19 vaccinations. Next slide. The outcomes and the benefits. So we benefit from having vaccinations and having a high amount of people that receive the vaccination by reducing the incidence of infection. They greatly improve residents' health and quality of life to ensure that they're safe, they're protected from communicable diseases that are available, that are vaccination available. Enhance safety and well-being for the staff. So we don't have a lot of our staff out because we didn't have huge outbreaks of COVID-19 or huge outbreaks of influenza. It's also a cost saving through decreased healthcare utilization. It is a high cost to be on a ventilator. We saw that. It is a high cost to be admitted into the hospital for any reason at all. It is a high cost to everyone around us to not have the staff member, not have the residents, not have them in rehab. It also is a high cost to what they're probably there for, whether they're there for skilled nursing or long-term care. If they're there for that skilled nursing, that just changes that whole dynamic of where their outcomes and their continuation on rehabilitation goes to, how long their stay. It changes our quality measures in that setting too. Next slide. The other cost savings that having people immunized for is reducing the risk of being cited, having monetary assessments for receiving a citation. That is a significant amount of money that doesn't need to go to that process. It could be prevented. In conclusion, we're going to go back through everything. Infection control and immunization practices are crucial in nursing homes. We use collaborative efforts among staff, residents, families, and healthcare providers. And we have continuous education and implementation of best practices. We want to ensure a safe and healthy environment for all residents. I can give you just one more little bit longer story that both Keisha and I, who's on the call, experienced in Illinois. And this was, I can't remember what year, but it was after the pandemic had hit, and then we were almost, a year into it. And I was the director of nursing at a facility in Illinois. And through all of this, I had 2 years of being, I think we were at about a year and a half or almost 2 years out from doing all of these directed plans of correction. And we had the Delta variant outbreak, which I believe, I don't think I ever got a word whether it was the Delta variant or not. But we had all of our residents that were vaccinated, and it was one specific vaccine. It was Pfizer. They were all double vaxxed. I think they were double vaxxed, but I don't think that they had a booster, or they might have. They had all the vaccinations, right? They had an infection, and I had procedures that said, yes, we bring people down, we isolate them, where's the COVID unit, all of these processes that we had gone through and had been set up long before I ever came into the interim role, long before Keisha ever came into this interim role as an administrator. And because of that, I wanted to know all their practices. I love infection control, so I wanted to know all of those things. And I based it upon everything that I had learned. If you isolate, you have to wall it off. It has to have a barrier. It has to have people that are just on that unit, that are dedicated to that unit for staff. And the reason for that is so we don't cross-contaminate and give it to everyone. When I started to see that the facility, the amount of people that the outbreak was potentially infecting, we put an entire floor on isolation because I couldn't track where it had gone, because it was a dementia patient and they couldn't give me a significant amount of information of who they talked to, who they were around. And it was a large population of dementia and memory care people. So we ended up having to isolate that entire floor. And we were able to contain the outbreak significantly, but it wasn't for not having to fight through some processes that allowed us to do so. And talking about fighting with a corporation to say, no, this is the way it needs to be done. And we did it that way. We reduced the infections. We were, I think, about 30 days out before we got everybody off of isolation. And we did have 3 people that passed away. And I think it ended up being 6 people that ended up passing away from it. Because of that, it was a significant event, fighting for the right thing. Later on, we left that facility. I moved on to the next facility, and I went back and I looked at their survey. And after I left, they went back to the practices of not having, just putting a sign up, not having barriers, not having dedicated staff. They ended up getting significant amount of citations, significant, to the point where they were advised by the director and the infection immunologist for the state level to do what I had told them, but they went back to that practices. And because of that, they had significant outbreaks again. It's important to follow what professionals are telling you to do. Next slide. Any questions, discussion? Sorry, I wasn't expecting that. Thought I had one more. Sorry. Questions, discussion, concerns, thoughts?
Well, we've had a few questions in chat which have been answered. I I love all of your examples and real life situations that I know could, you're just in your head, I'm thinking, oh God, yeah, I've been through that, or oh yeah, I know what she's talking about. Those are excellent, just excellent, Constance. I wanted to say that, is there you thought there was another slide? Are there anything you wanted to mention about any of looks like we got resources.
Yes,
And your contact information. I have a minute left. Was there anything you'd like to close with?
No, just if you have any questions, concerns, you have issues, you can reach out. My phone number's there, my email's there. I do check it on a regular basis. The last thing would be if you need resources, we did include some resources that would take you to information about the RSV, information about the new COVID-19, as well as there's a packet of information on the one that's from NHSN, I believe, that gives you other things that we went through but didn't go into significant amount of details. It's a really great resource, and I wanted to make sure we put it in there.
Perfect, and we did.
If you don't mind, I just need 5 seconds. Just wanted to reinforce and re-emphasize about making sure you're doing the right thing. When you know what the right thing to do and the guidance that are out there and you have documentation to prove it, being able to speak with your executive team or your corporate team and your facility is going to be key to making sure that you're protecting residents and your staff. So I cannot echo that enough, because Ms. Constance really did go to battle to make sure that the residents were safe within the facility.
Yeah, you have to be able to stand firm in what you know and what you believe. I'm not saying that you can't be amendable to changes in collaboration, but you really have to be able to advocate in a way that pushes what's the best practice. It's very important. Hopefully that's easy.
Nice. Yeah, this has been a wealth of information, Constance, and you can see here is her website and how to get a hold of her if you have any questions. And of course, reach out to any of us at Superior Health, and we can help answer questions and help you with your infection control processes and your immunization too. So with that being said, we're a little bit over. Again, I appreciate everyone being here. Thank you again, Constance, for this very exhilarating and great discussion. And bye, everyone. We'll hope to see you again in a couple weeks. Bye-bye.